Hi, Zach again. For homework number 4, I'll be discussing why there is no clinical distinction between bacteriostatic and bactericidal antibiotics. That's chapter 15, question number 1. Let's get into it. Every year, public health officials, healthcare workers, and researchers are presented with new and emerging treatments to bacterial threats. Some are harder to treat than others. In general, antibiotics work in two ways, as we can see here on this slide. The first, bacteriostatic drugs, are substances that inhibit the replication of bacteria, typically by means of inhibiting proteins or enzyme systems that are necessary for said replication. Secondly, bactericidal drugs cause the expiration of bacterial cells by hindering the stability of the cell membrane or by interfering with the proteins or enzymes necessary for maintenance of the cell's integrity. That being said, oftentimes clinicians are much more concerned with the causative bacteria than they are with the treatment itself, since most antibiotics are capable of being both bacteriostatic and bactericidal, as we'll discuss next. So I want to quickly jump into a little history. Around the year 1940, antibiotics emerged as a new cure-all for diseases and conditions. Because they were mostly poorly understood by many common people, not necessarily medical professionals, they became incredibly overused and overprescribed. For this reason, some believe this contributed to antibiotic-resistant bacteria, thus being bacteria that have evolved over time to resist antibiotic therapy and are incredibly harder to treat. Not to mention, there's a huge misconception in older generations that antibiotics work well to treat viral infections also. To help combat antibiotic resistant bacteria, clinicians and researchers are only left to develop new therapies or higher constituted doses of those medicines that already exist, which can unfortunately increase the risk of toxicity and ultimately increase the more resistant bacteria are. To continue from the previous slide, in some cases, a particular antibiotic can be both bacteriostatic and bactericidal, but this typically relates to the concentration of the dosage of the prescribed drug, the duration of the therapy, and/or the route of administration, and not necessarily the mechanism of action or the pharmacokinetics of the antibiotic itself. Adding to this, we often hear narrow and broad spectrum in reference to antibiotics in the clinical setting. This means that the drug either has an effect on a small group of select bacteria, such as the older penicillins or vancomycin, or they treat a wide range of bacterial infections, including those that are both gram-positive and gram-negative, excuse me. Those that are narrow and broad spectrum, respectively. The goal of antibiotic therapy is not necessarily to eradicate the harmful bacteria from the body, meaning clear it out completely, but instead the goal is to eliminate enough bacterial invaders to a point of which the human immune system can effectively manage and deal with the infection on its own, like it's supposed to. Typically, to determine what antibiotic is necessary to treat bacterial infections, a culture of sensitivity test is performed to identify the bacteria and its possible therapies. In some cases, when a patient is acutely ill or they present in a crisis or with a medical emergency, there may not be enough time to wait for a culture sensitivity test to be completed. So, in these scenarios, a broad spectrum antibiotic is typically administered to hopefully get a head start in treating the infection. These are my references, and I'm going to attach them separately.